Okay, good morning. Welcome to the fifth meeting of the Interim Joint Committee on Local Government. Glad you're here today. We've got a full agenda. So, Madam Clerk, let's please call the roll.
Senator Alvarado,
Here in the room.
Senator Harper Angel.
Present remotely in my district.
Thank you. Senator McDaniel.
Present in the 23rd District.
Thank you. Senator McGarvey. Senator Nemus.
Present in the room.
Senator Schroeder. Senator Southworth.
Here remotely.
Thank you. Senator Storm. Senator Thayer.
Here in the room.
Senator Wheeler. Representative Bentley.
Present in District 98.
Thank you. Representative Bray.
Present in the room.
Representative Brown. Representative Dixon. Representative Donahue.
Yes, ma'am. Present.
Representative Fleming.
Present in the room.
Representative Frazier. Representative Huff.
Present in the 82nd District.
Thank you. Representative Imes.
Present in the 5th District.
Thank you. Representative Johnson. Representative Koenig.
Present in the room.
Representative Lockett.
Here in the room.
Representative Marzian.
Present in the 34th District.
Thank you. Representative Meeks. Representative Miller.
Present in the room.
Representative Reed.
Here in the room.
Representative Roberts.
Here in the room.
Representative Thomas.
Present in the room.
Representative Meredith.
Present in the 19th District.
Thank you. Senator Mills.
I'm here in the room. Okay. We have quite a few people online today, members online. So at this moment, if you're online, can you please check your mic and mute that? We've got a couple noisy backgrounds, and then remember to unmute if you have questions when called on. Before we get started on our business, Senator Thayer has been asked to be recognized.
Thank you, Mr. Chairman. I have just learned that one of the members of this committee, Representative Deanna Frazier, has been awarded the 2021 Distinguished Service Award winner from her alma mater, Eastern Kentucky University. I have learned through reading it on Twitter, so it must be true, that political science was among her least favorite classes, which seems very counterintuitive to your chosen line of work here in Frankfort, Representative Frazier. But in all seriousness, this is a really big deal, and congratulations are due Representative Frazier.
Congratulations. We have two sets of minutes. We have 2 sets of minutes to approve for the August 26th and September 1. Can we approve those in one motion? Okay.
So moved.
Do I hear a motion for approval?
So moved.
All right. Have a second? Okay. All in favor, say aye. All right. The minutes are approved. Very good. Well, we've got a pretty good agenda here today. The first item on our agenda is the discussion of the health department's, health district's implementation of our legislation from the special session, and also just kind of a general discussion around health departments and their vital role that they are playing and have played over the last year and a half. So if the group from the health departments would like to come forward, we've got 4 guests, and come up to the desk and make yourself welcome. If you have PowerPoint or anything of that nature, do you need assistance getting that going? Okay. Mark will help you. He's coming down, right? Thank you. While we're working on that, if we want to start from your right and maybe introduce yourself across the line. And you may want to catch your mic there. It's the green light lights up when you're on.
Okay.
There you go. Pull it closer to you. Yeah. There you go.
Good morning. My name's Dana Nichols. I'm the executive director.
Still may not be on.
I'm the executive director of the Kentucky Health Departments Association.
Very good.
Georgia Heiss, Three Rivers District Director.
Sarah Jo Best, Director of Lincoln Trail District Health Department and the Kentucky Health Departments Association President.
Okay. And do we have Scott Lockyer on? Okay. Scott's back. Okay.
Yes, he's going to sit here as soon as I
That's
do
fine.
some introductory remarks. Does that look right?
Would you like to start without the PowerPoint?
Sure,
Or can you
yes,
start? Okay,
sure.
And she'll bring it on?
Yes.
Thank you. The floor is yours.
Thank you so much. As I mentioned, I'm Dana Nichols, the executive director of the Kentucky Health Departments Association, and we are an association of 60 local health department directors from across the state. And we do have, as introduced already, we do have Georgia Heiss and Sarah Jo Best here, and also Scott Lockard, who will be sitting at the table shortly. We also have 3 directors, I believe, online. We have Dr. Sarah Moyer from Louisville Metro. We have Clay Horton from Green River District down in Western Kentucky. And we also have Matt Rhodes from Oldham County Health Department, and he formerly worked with Dr. Moyer at Louisville Metro. So we tried to have a good sampling from around the state to be responsive to your questions that I know that you're going to have for us. But just a little bit more about CADA. We are a nonprofit association. I like to think of it as a professional association for local health department directors. We are a very busy association. I like to say that I work for 60 CEOs, which I thoroughly enjoy, but they are all very hard workers, both in their areas as well as for the association. Our offices are located here in Frankfort, and we focus on collaboration as a big part of what we do with each other, sharing resources, also communication with you, with the state government, with executive branch and legislative. Advocacy, so you may see us around sometimes, or you may have already, and also policy. We do work with the Babbage team, who's here supporting us today, and we do also work with KCO, and we're thankful to them for being our partners. And our mission is just to work together to improve public health in Kentucky. We do appreciate the opportunity to be here. We thank the chairs for inviting us to come and speak. I want to say that we're especially thankful for House Bill 129's passage in 2020, which all of you, I'm sure, voted for because it was very popular legislation. And we are thankful to Senator Alvarado for co-sponsoring that and for leading the charge in the Senate on that legislation, and also for the help on the pension in the last session. We're so thankful for that. So with that, I'll turn it over to Sarah Jo, our CADA president.
So as Dana mentioned, you have 6 local health department directors here with you today. And what's notable about that is we actually are representing about a third of the state today with those 6 health departments. So we represent counties from a population size of 4,500 all the way up to Jefferson County, which I believe is around 760,000 individuals. So very diverse for the area that we represent. What I want to talk to you about first is what local health departments do. And so this is what we were doing before COVID, what we're doing while we're responding to COVID. But I think what's important about this is to remember as we go through this presentation, this is all cumulative. We didn't stop doing services. So as we go through this presentation, you'll see a cumulative effect. So what does public health do? Public health transformation legislation really helped define this. And what it did for us is it provided an accountability for the public that when they walk into a local health department across the Commonwealth of Kentucky, they're assured a certain set of services or a minimum set of services. And this was important for us to be accountable to the public that we serve. It also provided some consistency, which could also make a wider impact across Kentucky. So regardless of where you are in the Commonwealth of Kentucky, what your zip code is, what your tax base is, there's a certain set of services that are assured to you. And I'll go through these, but foundational public health services are what we prioritize first. So public health transformation basically created a prioritization of services. So those foundational public health services are those services that are required by statute. And then second to that is the core public health package, which includes our WIC, CANS, and harm reduction program. I'll talk about each one of those in detail. What it does is it establishes that we must first use our resources in foundational public health services, then secondly, to support core public health services, and then if resources allow and we have a need identified within our local community, then we can branch out to specific services that might be identified as being needed specifically for that community. So our foundational public health services are those services, again, that are required by statute. And they include population health, enforcement of regulation, emergency preparedness and response, communicable disease control, and administration and organizational infrastructure. And I want to let you know what falls under that. Those are really broad categories, and so that's confusing sometimes about what that actually means, boots on the ground for the public. So our population health services really focus on prevention. That's what makes us a little bit different than the private healthcare world. And so we're always looking at ways to prevent disease, injury, or disability in whole populations. We use data to drive our decisions. We evaluate.
Ms. Bess, hold on just a second.
Okay.
Folks online, can you check your mic and mute your mic, please?
So that would be able to.
Representative Marzian? Thank you.
Yes, I'm muted.
Okay, thank you. Sorry to interrupt you.
That's okay. So this involves using data to drive our decisions, evaluation of our programs to assure they're effective and they're having the intended outcome that we want, and the impact of policies, environment, and behaviors that affect the overall health status of our communities. We do linkage of services in this area, so if it's not something the health department may provide, we're a trusted resource within the community that individuals will reach out to, and we'll link individuals to those community services, assurance of access of services within our community, and advocacy for good public health policies. Enforcement of regulation, that's most evident in our environmental health programs that regulate, permit, and inspect facilities such as pools, motels, schools, food service, mobile home parks, youth camps, tattoo parlors, ear and body piercing, sewage disposal, pumper trucks, as well as managing animal bites, rabies vaccinations, on-site sewage evaluation, and other overall threats to our population's health. Emergency preparedness and response, a lot of what you're seeing today, local health departments began planning for events like this as early as 2002 is when I started in our preparedness department at the local level. We were making plans for mass immunization, points of dispensing, whatever happened in our community, we were training, we were practicing. And as real world events happened, like the hepatitis A outbreak, or when we were deployed to Hurricane Katrina and Rita in Mississippi, we used all of those types of lessons to refine our plans. And that's what you're seeing today is really the implementation of plans that have been in place, trained, and exercised for many years. Communicable disease control. Boy, that's so much more than COVID. And other diseases did not go away because COVID arrived in our community. There are actually 103 reportable diseases, as well as conditions such as lead poisoning, waterborne, foodborne illness, asbestos, and other unexpected patterns of disease or outbreaks that have to be investigated by your local health department. Anywhere from 24 or immediately 24 hours to 5 days is our response time on those. And I can tell you that those did not go away or take a vacation during COVID. And administration and organizational management, that includes things like community health assessment, so assessing our community using qualitative and quantitative data, as well as community input to identify what we need to be working on within our communities, specific health concerns of our communities, and then putting that into action through community health improvement plans. Fiscal management of the local health department, program evaluation, human resource management, strategic planning, and technology. And then I'll go over our core public health services. So these are kind of that second tier. WIC provides federal grants for supplemental foods, healthcare referrals, and nutrition education for low-income, pregnant, breastfeeding, and non-breastfeeding postpartum women, and to infants and children ages 5 who are found to be at nutritional risk. This service saw a significant increase during the pandemic, and we had to alter the way we delivered the service to continue it. But we did have families that were depending on us to make sure that this continued. And so this is something that never stopped within our local communities in order to support those vulnerable families. HANDS In Kentucky, the HANDS program, or the Health Access Nurturing Development Services, is an evidence-based, high-quality home visitation program that promotes safe, healthy, and educated children. For over 20 years, HANDS has served families free, voluntarily programmed to support parents at home and help them learn how to be more engaged in their child's life. And I think that if everybody knew the 6 benchmarks of HANDS, we'd have way more referrals into this program than we're able to obtain. The 6 benchmarks are improved maternal and newborn health, reduction in child injuries, abuse, and neglect, improved school readiness and achievement, reduction in crime or domestic violence, improving family economic self-sufficiency, and improving service coordination and referrals to other community resources and support for those families. COVID-19 had an enormous strain on the financial, psychological, and fundamental well-being of vulnerable families, and so this program continued too. Now, we did have to alter the way we did this, and we started by calling our HANDS families, keeping them engaged, supporting them, but then we were able to move to more of like a tele-service where we were able to do that over video. Harm reduction. And that really refers to a lot more than I think that people understand, but it's policy programs and practices that aim at reducing the risk of harm associated with the use of substances. It's really about meeting people where they are, and it's so much more than a syringe exchange program. These programs are an entry point for vulnerable individuals that misuse substances. They often will not seek services or healthcare services other ways. It's a trusted entry point for them. In hepatitis A outbreak, this was critical in reaching that population and providing vaccines. And so we do that with this program, COVID-19. We can do testing, we can for HIV, sexually transmitted infections, Hep C. We can ensure that they get into treatment for those. We can refer them into community resources. We may assist them getting their insurance back to be able to enter into treatment programs. And so it's really a comprehensive program that meets people where they are. And then the icing on the cake is once we establish that relationship, we're more likely to get them into treatment than if they didn't have those services available to them. So, in summary, that's what we do on a daily basis, and we continued to do that during the COVID-19 pandemic. As you know, overdose deaths were an issue, suicides were an issue, all those types of things became an issue during the pandemic, and so these services were critically important to continue to support. I'm going to turn it over now to Dr. Georgia Heiss.
Good morning. So I'm very happy to be here. Thank you for inviting us. We really appreciate it. It's been a while. We've been a little busy for 18 months. I need to introduce a local board member who came with me, Mr. Joe Gilbert. He serves on the Carroll County Local Board of Health, and he has been very helpful during this, and he wanted to get the perspective of what it's like to do this, and also if anybody wanted to ask him what it's like to be on the local board of health. I would also have to give a shout out to Carolyn Stewart. She's 75 years old. She's watching me, but she is our purchasing agent at Three Rivers. She will kill me if I didn't do that. So, hey, Carolyn.
Can you pull your mic up to you a little bit?
Okay, so
There you go.
I also have to apologize for anything weird that might be going on with my mouth. I've had extensive oral surgery recently, so just bear with me. I would like to say that the group sitting here has done a lot of work in policy, but not for the last 18 months because we have been on the front lines at home at our health department, so we haven't been able to come to Frankfort. But before the pandemic hit, I spent a year, Senator Alvarado, Representative Moser, and we worked on House Bill 129 that turned into the public health transformation that our president was speaking about, and we were thrilled with that. So last, I guess March of 2020, we actually, some of us were on the Hill in D.C. talking about the decades of underfunding for public health at the federal level, and that's something I have done for 10 years, except 2021. I didn't do it this year. But it was amazing that we were there. There were people from Washington State who were just getting the first cases. That was March 2020. And then we come back home. That is the slide you're looking at, my Emergency Operations Center. That building has since kind of been abandoned. Different story for a different time. But the electricity went out, a storm. We're doing contact tracing, disease investigation via generator there in that building. That group of people, just like every health department across the state, once COVID kicked in, and it took a while to get like to Scott's part of the state, we spent 12, 14, 16-hour days, 7 days a week, and just trying to take care of our folks at home the best we could. And we were in the dark, literally and figuratively, because nobody knew what the new virus was going to do. We've done contact tracing, we've done disease investigation for years and years and years, but this was a brand new virus, so we had to see what it was going to do. So we spent a lot of time trying to educate and our communities and just get the information the best we could from the CDC, from the state, the places that were generating it from other countries. When was it going to get here? How quickly was it going to spread? And doing everything we could do about how to keep safe. And at that time, we had nothing but good old-fashioned public health, which is social distance, wash your hands, wear a mask. That was it. That was all the tools we had at the time to fight the virus. So we did jump in and do disease investigation and contact tracing the way we have always done it with reportable diseases. We know how to do this. With COVID, it really got ramped up to a different level. We're overtaken with it now, and the schools are having to do that kind of work, at least the contact tracing part, in their schools because we have so many cases that we can't keep up. And in the beginning, the folks that we talked to were scared and wanted to know, what we could do, what they should do, and very compliant, let me say, or willing to take any advice that we were giving. That they're not that much that way now. It's not. It's difficult to get somebody to answer the phone, really, maybe. Early on, we also spent much time with our businesses, especially the ones that stayed open through the shutdown, about how to space people out, the barriers. Every time we got new updates from CDC on how we could make businesses work and be safe and keep everybody doing what they needed to do so that food could be delivered, that the services that people are used to having could be maintained. That was a full-time job. That was also a new job for health departments. We really didn't know that we would be doing that type thing. Lots of tape on the floor, 6 feet apart, lines, what's your capacity, and those kind of educational pieces. We also were the distributors of the PPE, and that was great fun because in the beginning there was much confusion about the masks. We had a shortage, and just multitudes of things that went amok at all levels, but we did not have enough of the right kind of masks, so we tried to save the N95s, the masks that we did have for the folks that were on the front line treating the people with COVID. And so we had, the Girl Scout troops and the churches making masks out of, Winnie the Pooh or whatever material kind of things, but there was miscommunication about cause people to not really understand how the masks work or don't work. Then testing came along, and it was kind of the same way as the mask. When at first we didn't have tests. There was CDC issues, and didn't use the test from another country, and the things that went along with that. So in the beginning in Kentucky, we only had the state lab that had very small capacity to do testing. So people that weren't very ill, and then we had the original virus at that time, were urged to stay home and isolate. There would be nothing any different getting the test versus not getting the test. That's not so much true now. But so before we had very many tests, we were trying to get people to, not worry so much about the test, just to take care of themselves. And then fast forward, we got a Contracts with gravity, everybody wanted to test. We had all kinds of tests. They are coming out our ears. So all of this has been, we started out with nothing, and then we ramped up. By the time we got an abundance of stuff, then our people, our community at large, had decided we're done with this. We're tired of this. We don't want to hear any more about it. And then the vaccine. So we were thrilled. I felt like Santa Claus when it came to our health department. I did have my Santa hat on and rolled my sleeve up right away. Please give me that shot right now. And we had many people, and in my counties that are some of the worst vaccinated in the state, unfortunately. But I will have to give it to our folks that are 65 and older. They stood in line ready to roll, and we made sure they got the vaccine, and they're less sick than the other folks. But the vaccines are sort of the same as everything else, the masks and the tests. Before we had it, everybody wanted it. Now that we've got enough for everybody and their dog too, nobody wants it. So fast forward to where are we right now? So this is a Kentucky Hospital Association slide showing, and this was, I think, from Friday, but how many folks that we've had in the hospital and all of our statistics that are just, these are not statistics we want. We want on the other side of this. We, just like you and everybody else, want to move to a different Kentucky, to a different nation than what we've got going on right now. So this was a great day right here. This was 2020 when that bill passed, and we were thrilled and just waiting for, now we're going to get this funded. Public health is going to be strong. Little did we know at the minute we knew at some point we'd be faced with a pandemic, but we didn't know how quick it was going to be coming. And we were just on the edge of having this done, having the funding for foundational infrastructure for health departments, because this is what this bill is all about. And then we launched into nothing like any of us had seen before, the battle of our careers. And then this is where public health is. See us squished there between politics and science? That's where we are. And then throw in, social media and all that other stuff. And that is the tight spot we find ourselves in public health. And especially in Kentucky, because we're only one of 3 states in the United States that does at public health a shared governance system. We try to always play that to the best of our outcome if we can, but that means we answer to 2 masters. So the health department directors answer to the State Department of Public Health and also to a local board, which has a local judge executive sitting on that board as well. So the state and locals, that's not that way in the other states. In 2014, how I got started going on the Hill in D.C., I was the president of the National Association of County and City Health Officials, which serves the 2,800 health departments across the country. So Kentucky is only one of 3. The rest are either, if you're a health department, you are a part of the state government or you are a part of the local government, except we are kind of that in the middle. Sometimes that makes for very interesting happenings. So I didn't know if you all knew that or not, but I wanted you to know that's kind of how our reality is, and it has never been more of a challenge than this past 18 months.
Okay, I'll take it from here. Again, I'm Scott Lockard, Public Health. Turn on my mic. Scott Lockard, Public Health Director, Kentucky River District Health Department. I serve Perry, Knott, Letcher, Leslie, Wolfley, and Owsley counties in the far eastern part of the state there, neighbors to Pike County. And prior to that, I was Public Health Director in Clark County, so I had the privilege to work with Senator Alvarado there for 12 years. This chart right here kind of shows, when we start talking about public health, I'll often ask whenever I do a presentation to a group, how many of you all have ever received a service from your local health department? And we'll typically see a couple of hands go up because a lot of people think, well, we're clinics for poor people. But when you look at what all we do here, have you ate at a restaurant? Have you bought groceries? We touch every member of the Commonwealth of Kentucky every day. I've often said that in public health, it's the only place I know of where you can work with issues dealing as a director, from pap smears to rabies, all in the same day. And it's really going to be an interesting day if it's the same patient you're dealing with both issues on. So it's never dull. There's so much going on. Our public health system is so much more than our local health departments. This gives you an example of what a public health system looks like. Law enforcement, they're a big part of public safety, so they're a big part of our public health system. Our nursing homes, we've been working hand in hand with them throughout this pandemic, a big part of the public health system. Economic development, our chambers of commerce, the best way to raise health status is to raise socioeconomic status, so we're big advocates of the business community and trying to work with them and get them the tools they need to effectively stay open and make a profit in a safe environment. Substance use disorder, as was touched on earlier, drug treatment. We have seen so many issues here throughout the pandemic, and it has exacerbated many of the reasons why some people use substance. Isolation, mental health issues, who among us in the past 18 months hasn't felt some anxiety, hasn't been depressed at times, has not had stress? There's just so many different things that we deal with on a daily basis. Our schools are a very important partner. So much public health goes on in schools. Some of our health departments still have school health programs where we actually provide nurses for the schools. All of us have been working with our schools throughout this pandemic, and just so many issues that they have been dealing with. My heart goes out, and if you're not aware, the Lee County school system had their third employee die yesterday from COVID. So their guidance counselor, who was much beloved in this small community of 6,500 people, it's just been devastating to the local community there. It's truly been devastating. So my thoughts and prayers are with them. You see the image of a conductor. Many times what the health department, the main role we're doing is we're convening entities in the community. We are that impartial third party who can bring together the FQHCs, the rural health clinics, the hospital system, the schools, the fire chief, the police commissioner, all these parties around a table, and let's do that community health assessment. Let's assess our strengths. Let's look at our opportunities for growth, and then let's do our CHIP, our Community Health Improvement Plan, so each entity is addressing those things which they are uniquely equipped to do. A lot of our fire departments and law enforcement partners do a lot around car seat safety. So if that's being done by them, we don't need to do it. We are very much a do or assure model. In many of our bigger communities where we have a lot more partners, we are just doing this conducting. We're making sure that we're linking people to whatever needs to occur. In some of our small communities like Owsley County, 4,500 people, it's too small for a private for-profit home health agency to make it there. So, I'm one of the few remaining public home health agencies in the state to make sure that very valuable service gets delivered. Next slide, please. Throughout the pandemic, again, we have been doing all these other services, and we've been doing it under challenging situations. What you're seeing here is the record flood that was in Lee County, where we saw water 4 feet deep in the streets, the biggest flood they've had since the 50s there. And this is one of our partners from the Department of Public Health, our immunization specialists there, who we worked with emergency management, and we boated in to save the COVID vaccine because it was so precious at that time. We had so few doses. When water got over our generator, I was not about to let that water, let our vaccine go down. So we boated in and we saved our vaccine. So we've dealt, two of my communities have had record floods, 100-year floods this year. And so our environmentalists been working with the community in response to that. Our FQHC that has served Lee County, their facility has been flooded out. And so we see a lot of people that were going there for cancer screening. Now they're not going to the adjoining county where they have relocated at their home office. And so we see more demand for our services. Testing, we're the primary testing provider there in Lee County. So there's just lots of different things that we're doing. Again, health departments that do or assure, if it's being done, we back out of it. If not, we get in there. Okay, next slide, please. So, what have we done as a result of the special session? And again, thank you all. We appreciate your work here to promote the health. I think we all have the same goal in mind. How do we have a healthy Kentucky that's economically prosperous for its citizens? That's what we all want. We all have common interests there. So the information here, the Test to Stay program. This is a program that we'd actually had conversations about and looked at some models, and we have been working with our school system. The State Department of Public Health has already put out guidance, so we appreciate them for that. Some of us had already put out guidance to our local communities as well based upon a draft that they had circulated a while back. And these Test to Stay programs, the key components of Test to Stay and what the science says, how they are effective, is that we have universal masking in the schools, that we're testing daily, because that way you're finding out which individuals that would have had to quarantine normally are now testing positive, because we have a 48-hour look-back window once someone is positive. And if you're only testing every other day, you're going to miss people and you're going to have more positives, and then you're going to have to go back and pick them up. So you have to have the logistics, you have to have the testing vendors, and the State Department of Public Health had contracted with vendors, and they are out on the website, and the KDE has shared that information along with their guidance. So the school superintendents, we have been working hand in glove with those. I have 9 school superintendents in my district there, and we talk. They have my cell number, and we talk and text at countless hours. The other issue there, of course, the big one is the statewide mask mandate. So again, local control. Here in the health department, you're going to find we're big fans of local control. We like it at the local level, and we appreciate that. We want to be able to talk with our local elected officials. We want to be able to talk with our local school officials, because my district's 90 miles apart, just Kentucky River. What may be right in Whitesburg may not be right in Beattyville. And so this gives us the opportunity to do what we need to do. And so, again, we appreciate that. Our local superintendents, I worked with several of my superintendents, as I know my colleagues did, to get them the science on the masking, and we see how many of them elected to continue to mask because we're at record levels. The number of patients I had in my district, and again, I use those numbers because that's what I'm most familiar with, from March of 2020 to the first week of August, we had 10,000 positive cases. Since the first week of August to last week, 6 weeks, I had 5,000 additional cases. That's how much Delta has kicked our butts. It's just the transmission, and Dr. Alvarado, if I get this wrong, he can correct me here, but the R0, we're seeing for every Delta variant patient that they're probably infecting another 7 patients roughly, whereas previous strains, every positive was infecting 1 to 2 other people. So again, it's just been, we really feel like we're on the front lines of a war out there. Our hospital beds, I work closely with the ARH system, and the ICUs are full, ventilators are full. They've been on diversion several times. We've had days here with less than 100 open ICU beds in the entire state. So it's really, we're truly at the height of this pandemic in our response. Next slide, please. The Senate Bill 2 provided that the regional COVID-19 antibody administration centers, the monoclonal antibody infusion centers, say that 3 times fast. We call it BAM down in my neck of the woods with our local providers. And so, setting up those regional providers, but now we've been told because of the COVID situation, the spread of disease, that they're now limiting these BAM, the monoclonal antibody treatments to about 4,900 a week. So they're having to ration those basically. So everybody that wants one of these may not get them. So I think this is one of the things too we'll be ready to respond with, and DPH has already engaged us and asked us, do we have providers in our area that are providing this? Is this need already met? Do we have the need for additional centers there? So we're working with that. PSAs and public awareness. Here's an example of a public awareness campaign we've already been doing. All my peers Social media has been, bombarded with this. We've been doing television ads, radio ads. This is a billboard in my district there where we got one of the younger folks there because we were targeting vaccines towards one of the youth, and we targeted one of the youth there in our schools and tried to, again, get these local champions. Who are your local champions? Who are your local medical professionals? We have seen that instead of the legislature telling people what to do, us at the health department telling people what to do, if their doctor tells them what to do, they're going to listen more. So that's very, very important. And that leads us to the next step, the distribution of vaccines at these regional distribution hubs. We've already been working on that. The picture at the bottom there is a super cold freezer that will store the Pfizer vaccine at that negative 80 degrees that's recommended there. So a lot of us in the health departments are agreeing to go ahead and be a regional distribution hub so we can get these vaccines. Pfizer only comes in lots of 1,170 doses. Well, the small physician practice on the corner doesn't need, they can't take that. So they may only need 18 doses. So what do? We get the 1170 and we're going to get the order from them and we're going to take them down 3 vials so they can have that 18 doses. So again, every opportunity we have to get a vaccine in the arm, that's what we're trying to do right now. We want no stone unturned. And by utilizing our local providers and not missing these opportunities, that's going to be a big part of it. And also, too, Senate Bill 2 added local health departments to KRS Chapter 13A and 39A. Just about that, I guess, any local health department mandates on vaccine there was that opt-out provision and things like that. And again, none of my peers that I talked to are wanting to do this at the local level. We're wanting to work with our policymakers on all this. Next slide, please. The Senate Bill 3, the appropriation of the funding, this is greatly appreciated. Again, many of us are involved in testing and vaccination, whatever our community needs. If we have other providers that are doing it, in my 7-county district, Primary Care Center of Eastern Kentucky and Perry County and Mountain Comprehensive Health Corp have got Letcher, Perry County all taken care of. Wolf Lee and Owsley, I have very few providers, so we're standing up and doing the testing ourselves down there. And this is my testing team, 2 members of that testing team down there, and we're testing daily there. So, and again, funding to do and provide the testing for the test to stay and all these different things. So ultimately, at the end of the day, whatever's decided here in Frankfort, we at the local health departments, we're glad to serve as your subject matter experts, provide you the information, provide you the pros and the cons, but once a decision is made, we're where the rubber hits the road. We're going to implement it at the local level. We live in those local communities, and we want to do what's best for our friends, neighbors, and families. Thank you all.
So public health has long served as invisible guardians, and we work across all areas of life. And for many of us, COVID-19 changed, I guess, the public's perception and understanding of that. We were happy being in the background and taking care of our communities, and we found ourselves kind of shoved out to the front, where what we did became very visible and even publicized and sometimes even criticized. What we ask for moving forward is that the public health transformation legislation be fully implemented. We need public health transformation funding according to the law, the way that it was spelled out in the formula. And so that hasn't happened. That's the only part of the legislation that hasn't happened to date. The rest of the items we've put in motion and put in action, both at the legislative level, the state level, and the local level. So that's our continued ask. And that would be in addition to the pension subsidy that we're receiving through House Bill 8. We have been very honest and upfront that to support both of those pieces of legislation, we would need both, not an either or. So that concludes our information part of it. You do have myself, Scott, and Georgia in the room. I just want to remind you that you also have Dr. Sarah Moyer with Louisville Metro Public Health, Clay Horton with Green River District Health Department, and Matt Rhodes with Oldham County Health Department on the line, and we're available to answer your questions.
Very good. Thank you so much for that presentation. That was exactly, I think, what we all needed to just kind of a review and overview of where we get so many questions about the health department, and it's just good to get a review on how you function and what you're doing and how busy you are. And we obviously all are very appreciative of your services and the long hours that you've put in the last year and a half. So we probably have a couple of questions. We'll open it up with Senator Alvarado.
Thank you, Mr. Chairman. Obviously, you're going to bring Health and Welfare Committee issues to any committee outside of Health and Welfare. I got to talk, so I appreciate the opportunity. Just to let people know, as a practicing physician in Clark County, a list that I just started writing things of what I've contacted the health department for, and I never really done that list before, but I think of all the STDs we saw in our office, like you mentioned, pap smears, people coming in with complaints, and you find something, you have to report that. Substance use disorder, resources, tuberculosis, people have had TB, people have come in from other countries with TB, they haven't, had treatment, how to treat them. Sometimes people that refuse treatment for that and are infecting others and then have to be quarantined for those purposes. Influenza, cryptococcus, which is a waterborne disorder, all the hepatitis A, B, and C, rabies. I've had people trying to rescue raccoons get bitten, have to require a shot, and you can't get those. I mean, those are really specialized in how to give them. The health department's a resource. Immunizations for kids who, the few that have fallen in between where they don't qualify for CHIP or other things have to get immunizations, WIC programs for babies who need formula, all of those things. So just some of the things top of my head that as a practicing doctor, I've had to contact the health department with for assistance. So I do appreciate all the work that you all do. We know how important it is. A couple of quick questions. On Senate Bill 2, some of the things I would urge you, if the Department of Public Health and the Cabinet's I wanted to be more prescriptive in that bill that came through. It's more of a please assist and help is the language that's used in that bill. So if they're going to turf that to you all, then please do. I mean, what we've heard from a lot of our providers is that we haven't gotten help from the Cabinet on these things. And they said, oh, we're helping. And almost all the providers I talked to said, we're not seeing it, we're not feeling it. So on issues like Regeneron, the federal government's now restricting that. I just called my hospital in Clark County. They were ordering 200 doses a week. They were given 40. They said that'll last them about a day and a half. Norton's has had the same kind of issue. They've requested so many they were giving. So the feds are rationing that. I'm not really sure why. I don't know that it's a manufacturing thing. I'm not sure why they're rationing it. There hasn't really been a good explanation for it, but we need to see if we can bump that up however we can and get that into folks. It's going to keep them from the hospital. Doctors' offices need vaccinations as well. I know they can't store Pfizer and Moderna, but Johnson & Johnson they can. It's paperwork is the headache for those doctors. It's like a 20-page document to fill out. And all a doctor hates to hear is, all you have to do is, if you hear that, they don't want to do it because it's just another piece of paperwork for them to fill out. Anything we can do to do that. The public service announcements. We need to be graphic with our public service announcements. Take someone, if you can get someone who's 30 years old, who hasn't been vaccinated, who's about to be put on a ventilator and film that moment before the last words before they go on an event and put that on television for our young people to see, that will be a bigger impact almost than anything. We've seen that with tobacco kind of advertising and that sort of thing. A couple of quick questions for you. What's the current funding that we need for House Bill 129? I think that's important for this group to hear that number.
So the estimates, we are still working on finalizing that detail. We're using closeout data, and so some of that is just being approved. But the estimate at this point is between $7.7 to $19 million for fiscal year 23.
Okay, very good. And that's important I think we hear that in health and welfare, and I've put the request in myself, but it's important for those who aren't on that committee to know what the amount is and the kind of work that you do. I think that price tag is going to be well worth what we need moving forward also. I've often talked about also the importance of considering our MCOs and Medicaid and trying to blend them with our health departments. Some states have done that because you all are closer to the ground. You know your communities. You know the needs that are in those communities. So maybe thoughts on that. And then also the biggest threat for our health departments right now. I know some of them are in better fiscal shape. Some are not. Maybe you can just touch on that very briefly. From what I understand, several at risk of closing. Maybe you can touch on that really quickly.
Scott, I'm going to defer that question to you.
Okay. I get that question a lot because the local funding issues vary greatly. The base of a health department's funding is the local tax base, and many of our health departments, the tax that is required by the statute is 1.8, is what the commissioner sends it at. But many of our local health departments in smaller counties are at 8 cents or even 10 cents, which is the maximum. Now, I have a situation in Letcher County, and it's a prime example here of how, again, health departments differ greatly, and our financial needs come to the forefront here. In 2014, the local taxing district generated $1.2 million in the Whitesburg and Letcher County system. And so we have a health department down there. You know, they had built a new health department based upon financial data and the needs at that time. Well, now, since 2014, things have changed. You know, unmined minerals, the legislature changed the way we tax unmined minerals, and oil and gas leases, and coal mining is just bottomed out. So this year, the estimate for next year is that the local health taxing district will generate $540,000, down from $1.2 million. You know, I can no longer afford to pay the payment on my health department, much less pay the pension if we have that stair step down from House Bill 8. You know, and that was the thing, House Bill 8. And I know I saw David Eagers, we come in this room, and we all look forward to the day when we don't say the P word or the C word anymore in here, right? We get away from COVID, we get away from pension. But those, you know, that is the biggest threat to my health department right now is equitable funding. We're losing tax base down there, and the people that are leaving are the ones that need public health probably the least, you know, and so we're seeing that. So that's very different on and we need to take a look at that, how we really address that equitable funding issue and so on.
Representative Miller has a question.
I would just like any of you all at the table, and also Dr. Sarah Moyer, who's online, in the last 2 months, have you seen a change in the trend in terms of number of people seeking and accepting a vaccine? Because in my mind, we ought to be vaccinating a lot more people than we were in June when it, you know, before COVID really smashed us.
Dr. Moyer, I'm going to go ahead and turn that over to you.
Thanks, Sarah Jo. So the trends in vaccination it was the highest in March when supply was still limited. Everybody wanted it. Definitely went down through June. We saw a little bit of an uptick in August when Delta first hit and people were nervous, but those numbers have started trending down in this last week. I think the next big bump that we'll see will be when more workplaces, when it becomes a condition of employment, is what we're predicting.
I would say that that's pretty consistent across the state, her answer.
Just troubling. Thank you.
We had an uptick when we were allowed to give it to the up to 12 to 17-year-olds. So the folks that wanted that for their children. And then I think we'll get it again when we get something approved for the 5 to 11-year-olds. But we kind of had it's not picked up for us. I mean, it was heavy duty when we first got the vaccine, and then people got, depending on the vaccine they got the second dose. But once we got those people taken care of, it's kind of been, just fell off.
And that's where the PSAs and the public service announcements, I appreciate the elected leaders in this room have put out things on their Facebook and different things supporting people making that choice, getting the information and getting vaccinated. There's so much misinformation and disinformation in Eastern Kentucky, where I'm from. Owsley County has a vaccination rate of about 34%, up to the highest in Perry County of about 58%. But we're constantly combating misinformation, disinformation. We're not trying to microchip people. I can care less what they do. I hope they go out in the woods and have fun, and so it's just getting out that accurate information there, that we're not rewiring your DNA and doing all these different things, but this is medical science, a modern medical miracle, as Senator Mitch McConnell says, and he recommends everybody gets vaccinated. So we need more of that. We just need to really, really flood the airwaves and social media and everything with people who obviously, I'll turn it back on around here for a second, but you all are respected. You all, obviously, you win elections, you get here. People value what you all think too. So I would challenge each of you all, how can you help us in this battle and to educate and inform? Again, not mandate. I prefer people make their own decisions too, but I prefer they make it with the accurate, factual information.
Thank you. Thank you very much.
Go Colonels.
Representative Roberts.
Thank you, Chair. If I could first just thank you all. I mean, your efforts in the last 18 months have been absolutely Herculean. I do have a lot of contact with my local health department, and I'll just give a shout out to Dr. Lynn Sadler, who just recently retired, and to Steve Devine, who's taken over the mantle there. And just, you've had such an 18 months, so thank you for everything you do. And you know, I love that you were talking about what your normal activities are outside of COVID. And I remember last summer when COVID was starting to die down, and then the great pool opening debate of the summer of 2020 took over, and you all had to get all of those pools open as fast as possible. I think I got more emails on that than I did COVID in July of last year. I have two questions, if I may. The first is, can you all talk about where your WIC programs and all of those outreach programs are concerned? Are you starting yet to see the benefit, perhaps, of what the expanded SNAP benefits we're doing for families, and then also what the tax credit for children is doing for families? Is it too early for you to see that? Are you seeing any impact yet?
I'm trying to think of who the best person is to do that. I'm going to turn it over to Scott.
Yes, in our area, we're seeing benefits. You know, we have very high poverty rates. Again, Eastern Kentucky, poor health outcomes, high poverty rates. There are certain things, and I know we always, you know, I'm a very optimistic, strength-based person. There are things that have happened during this pandemic that I think have improved service delivery. Our WIC service delivery rate, participation rate, is the highest it's ever been. And so we're seeing people engage. You know, we need to remove barriers so we can communicate effectively as much as we can do. We do hands visits through Messenger video chat now. And you know, if we can't get in the home for a reason or whatever there, now we can use technology. So I think we're seeing benefits from this. We're also seeing benefits that there have been a lot of food distributions. Wolfe County, where I'm from, the local fire department has actually opened a food bank with a grant from Anthem and pulling in other resources. They've been serving people from about a 5-county radius, and the last giveaway they had there last week, they served over 1,350 families. So there's still a lot of food insecurity out there. I think we're seeing some positives, some gains, but in areas of high poverty, there's still a lot of need.
Thank you. Mr. Chair, if I may, one more quick question.
You may. One.
A concern I have, especially with told that this is taking on our hospital systems and so on and so forth, is your reporting, the reporting that health departments give to us is so vital for the policies that we craft and the budget that we craft, especially with our substance use disorder upticks in the last year. I'm really concerned that we may see some underreporting on things like HIV spread and hepatitis C spread in our communities. Can you talk about where we may have some needs in the data as we're making those policy decisions in the next year?
Dr. Moyer, I'm going to send this question to you because I know your team has been working on specifically with HIV.
So I just want to start by thanking you. I think the hardest piece with our data right now is, I think about 20 years ago, our healthcare systems went through kind of evolution where the electronic health records were mandated. Your health department still is on paper records. And I know we've got a system up for contact tracing, but besides that, it's just really hard to get that data in and sift through it. And so I'm hoping that'll be one of the positives that comes out of the post-COVID pandemic as we get brought up to speed with all the technology resources that are up there, so we can keep better track of it. And then with HIV and other data that's not being followed, we are tracking that closely. I mean, it's still reportable. As Sarah Jo mentioned earlier, it's just the staff and the time to sort through it, but it is something we're tracking closely.
And another thing on data, I will interject here. Some of our health departments in our communities have great deficits in internet service. And the key to a good data system is high-speed internet and broadband. And my district office, the best speed I can get right now is 4 meg download and 1 meg up. So if I'm doing a Zoom meeting, nobody else in my district can work that, on the computer. So we're working through some of the infrastructure investments and stuff that hopefully by January 1, I'll have 1 gig down, 1 gig up in each of my 8 offices. So a lot of these things, again, we're being able to invest in and see and to get those services out there.
Senator Thayer has a question.
Thank you, Mr. Chairman. First of all, I appreciate your monologue on local control. If I knew how to do a TikTok video, I'd put it together and send it to the governor, but I don't, so I won't. But I do appreciate that, and I think probably one of the most important things you can do right now is work with our school districts so they can be flexible in keeping kids in school for in-person instruction, and hopefully eventually getting these masks off these kids' faces so we can get them back to normal, because I'm very concerned about the societal effects, the cultural effects, communications effects, the ability to learn while these kids are wearing these masks. But I think that's really important for you all to stay in touch with school boards and superintendents so they can move more quickly at the local level than we could have had a statewide ban on masks stayed in place. So thank you for that. I have two questions. We're all very concerned about the unintended consequences of the lockdowns and the shutdowns and all the things that were done to deal with the pandemic, the mental health consequences that you talked about, increases in drug use and overdose deaths, mental health, suicides, et cetera. And I'm curious if you've seen a spike in the requests for the taxpayer-funded needles at needle exchanges that we fund for illegal activity in the Commonwealth. And you can probably tell I'm not very happy that I actually voted for that several years ago. I wish I could have it back. But we had to get the heroin bill, the opioid bill, across the finish line. That was the only way we could do it. So I'm interested in those numbers. Have you seen a spike in the requests for the needles at the needle exchanges?
I think that varies from area to area and how long that syringe service program has been in place. So I know in my area, in Marion County, we have seen an increase in that service. In LaRue County, a smaller rural county that we just started that program, we really haven't seen that same increase. So I think that varies from place to place. Overall, in Kentucky, our hope is that the participation will increase. And that's really because fundamentally those programs are meant to prevent communicable disease in our communities.
I'm well aware of why the healthcare community is in favor of them. I have a freedom and liberty and a taxpayer funding issue of funding illegal activity. So we're just going to disagree on that. So just tell me the numbers if you can.
So I don't have the exact numbers, but we can look that up for you. We do track that statewide through a program called Red Cap, so that's easily available to get.
Thanks. I'd be interested in knowing that.
Again, in Kentucky River District, we just pulled the numbers the other day. Our first program went live in August of 2017. As of last month, we have exchanged over 1,200,000 syringes in my 7 counties with a 98% return ratio. And we use grant funding for the syringes, where we've been able to secure grants to buy, because I know it's a very issue that is sensitive to a lot of people. But with the levels of HIV and Hep C and everything in our community, and we have, yesterday I was on one of the most moving testimonies I've seen in a long time, was a young lady who was engaged when she talked about being prostituted at 13 for the next fix. And now she has gone through treatment at Addiction Recovery Care. And she has now become a peer counselor. And she was studying for a history test. And this young lady who used to be prostituted, and her pimp, her drug dealer, saying, "You're sitting on a gold mine there," referring to her sexuality, and that we can have all the drugs we need. And to see this lady now, who is no longer injecting, who has been referred to treatment, who is now a young girl, she's the same age as my daughter, and I looked at her and just who is worried about making a grade on a history test. Ain't that what young girls are supposed to be worried about, instead of being prostituted out for the next hit? So it's making a difference, Senator Thayer. So even if you regret the vote now, I appreciate that you voted for it. Thank you.
I know you do, and I appreciate. And I wish we had more stories like that. But unfortunately, over the last 18 months, we've not. There have been more bad stories than there have been good. So I'm going to switch, and I'm curious about those numbers if you can provide them on a statewide basis. I'm going to switch to another topic that causes us all anxiety. You mentioned pensions. Please tell me you're not going to come back and ask for more pension reform, because what we did to get you where you are was a really heavy lift.
And I'll speak to it from Kentucky River District. All along, as we've come and talked about this, there were a few of the health departments that we knew because, again, declining tax base, and Representative Miller was in on these discussions all along. There was a handful of health departments that we knew would never be able to do that without the House Bill 8 full funding there. So, what we're going to talk about is, again, present the pictures, because health departments, where does our money come from? You know, we're publicly funded. We've got this local tax dollar, and then it comes through the federal grants that are funneled through us, and then the general fund dollars. So at the end of the day, you know, we can't make more widgets and sell more widgets and generate more profits, because since public health, the Affordable Care Act expansion, the FQHCs, all the other entities now that for people that have Medicaid, they're providing these services, and any service where we used to could turn a profit and turn that money back into, I guess, as a surplus. We weren't supposed to say profit, were we? But we take those surpluses and fund public health with them, has been drained off from us, and we're left with the remainder that nobody else wants to do. So we'll always give you accurate pictures. House Bill 8 took care of the problem for the majority of our health departments across the state. You're still going to have a handful, Cumberland Valley District, Kentucky River District, a few of the others, you know, Three Rivers, that we're going to have some conversations about, because right now, too, one of the issues I know that's near and dear to all of your all's heart is the workforce development issue. We have people, you know, who are drawing unemployment, who, for whatever reason, are not re-engaging in the workforce. Well, health departments are not immune. Used to, our pension was the main selling point, the way we recruited people, and said, well, we're going to pay you less than you make in the private sector, but you're going to have a stable retirement, so we could recruit with that. Now, with Tier 3 benefits, that's no longer there. So it's really hard for me to recruit a nurse at $19.50 an hour when ARH is starting them at $29 and paying up to $55 an hour at the local hospital. And if they become a travel nurse, they can get $100 an hour right now. And so these are the type of people we need too in public health. So we're left with no choice, but there has been a great upward pressure because of inflation, workforce issues. There's an upward pressure on salary levels. And so again, we have to have people to do the work that we do, and we're doing it as efficiently as possible. At one time, Kentucky River District had over 300 employees. I've got 120 today. You know, the efficiencies and economies of scale, we've cut to the bone.
The Tier 3 pension plan is a good plan.
Sure.
I was the sponsor of the bill.
Mm-hmm.
So I get a little bit testy when people come in here and try to tell me that that's not a good plan. It's a good plan, and it's got the state KERS plan moving in the right direction, which it's our responsibility to make sure that that doesn't go broke.
Yeah. And so please understand what I was saying there. I think it's a good plan too, is what needed to occur. But as far as when we're talking with people, you know, they 27 and out was a big draw for us before, and now we can no longer afford that. So we're just being honest with them. We tell them what's there, so that they want higher salaries now as a result.
Senator
Thank you.
Senator Nemeth has a question.
Thank you, Mr. Chairman, and thank you all for being here and let us know you do a lot more than people think, and you actually get down and dirty. You come out and check my septic system out. So, but my question is, the percent of adults, do you have the numbers on that have had COVID and are vaccinated? The combination of the two. Do you have those numbers?
I do not have those numbers in front of me. We do have those numbers. I'm not sure if any of my peers have them with them today. An important note about that, and I know it's been debated, when we look at individuals who are fully vaccinated and get COVID, there's a very specific definition of fully vaccinated. It means that you have completed your series of vaccinations and you're 14 days out from that. And so when you're looking at data that if you're not fully vaccinated, if you've only received one dose of the 2 dose, or you haven't had your 14 days out from the second period, you don't have the full immunity that the vaccination would provide. So I just felt like I needed to tell you that, because there's been a lot of confusion about that. But that information, we do track that as a Commonwealth. We track that within our jurisdictions, but we also track that as a state, so we can get you that data.
I understand that, but what I'm trying to get at is, how safe are we? Because if you've had COVID, your immune system is better than if you've been vaccinated. Of course, if you've had COVID and vaccinated, you're better than everybody. So I want to know who has had COVID and who has been vaccinated. If you want to stipulate who's been fully vaccinated and add those two numbers, that's what I want to know.
So I can tell you what we're seeing locally is having COVID is we are seeing people that have had COVID and not long after get it again. So that is not as protective.
I do understand that because the vaccine's 70%, it varies, but it's 70%. So your 30% of your people, even vaccinated, are still at risk. And if you have not had the vaccine or COVID, you're at risk. But what I'm getting at is basically, if you've had COVID, your immune system is better than if you've been vaccinated. But I'm going to say, let's say they're equal. If you've had COVID and are vaccinated, you've had one of the two. That's the number I want to know, to see the percent of people that have had percentage-wise, that they're immune.
I'll have to look into that. I'm not sure that it's tracked if you have had COVID and you have been fully vaccinated.
No, I don't mean that.
Okay, I'm sorry. Maybe
you know how many people have been vaccinated?
Yes.
Okay. Do you know how many people that have had COVID that have not been vaccinated?
That's going to be a hard number to track because early on, a lot of people had the virus and didn't know they had it, or they had it and they were never entered into the system. They didn't go get tested. Remember when I talked earlier about when we had the test, but we discouraged people because we had so few. So we can get you the numbers of the people that had it and tested and got logged in the system. But if they had it and didn't get tested, that's unknown.
But y'all always talk about, and rightfully so, all the number that have been vaccinated and still catch COVID. That's why you need the protection of being 6 foot apart and mask and all that. So if you know that, then you should also know the ones that are, if you know the ones that are catching it that haven't been vaccinated, then you have a number of those catching it. That's what I'd like to know, is how many of those people have had COVID that you knew weren't vaccinated.
We can
along
get
with
the
the
data we
vaccinated.
have.
Yeah, we can get you the data we have.
Representative Donahue has our final question.
Thank you, Mr. Chairman, and thank you all today for the presentation. It was excellent. It was a lot of good information that hopefully the public will get exposed to that. We're debating about the booster shots and who hasn't had it and who has a shot and who's not doing what. The bottom line is that we know that the COVID-19, the shots work. We know that. And so I would ask our colleagues here, and out of respect for the folks that came here today, to step up and say, come on, folks, let's get a shot. Okay, let's establish a baseline. Let's take the shots. If we have to wear a mask, let's wear a mask. Okay, and then let's take a look at what, after we do that, as we move forward, we deal with the variables that may come from that. But we can debate this all day long. Shots work. Let's get shots. Thank you, sir.
Thank you. We're running out of time. We've got another presenter behind you, but just to kind of bring this all to a head here, obviously from our special session, the two things that we thought are very important for health departments: test to stay, monoclonal antibody treatment. You talked about monoclonal antibody treatments and right now how they're being evidently squeezed by the federal government. Hopefully that will be resolved soon because we know that works. But the test and stay, are there plenty of tests out there amongst our vendors? Do our superintendents know how to get a hold of those to where they can set up testing facilities within their school system? Just kind of clear that up for us so we know how to communicate with our constituents back home, because I think there's a little bit of misconception that the tests aren't available. And even in my area, Clay's on the line, we had a time when they were trying to test and stay in Henderson, and I had a call from a young lady. She had to wait 3 days to even get a test appointment. So, and then also, are these rapid tests? Are these the 24-hour tests? Can you clear that up, please?
How you doing, man?
Clay, do you want to take that since you were mentioned?
Sure, glad to. Thank you, Senator Mills. So, throughout our experience here, there have been times where we've had limited resources on testing, and there have been times where that's not been as big of a challenge. So here recently with the Delta surge, in some of our communities, we have heard of some short-term supply challenges. But overall, we're in a much better shape than we have been previously. There's a series of vendors that are set up in the system that the school systems can sign agreements with. And I think it depends on which vendor you speak to about what mechanism they're going to recommend versus a rapid test or a PCR test. In the model protocol or the model guidance that the Kentucky Department for Public Health and local health departments have provided to our school systems, there are procedures using both PCR and rapid test. Those here in Green River District that have announced that they're going to do test to stay program are planning to use the instant rapid test at this time. If there's any discrepancy or question about the validity of that test, they have the ability to follow up with the PCR test, which is the gold standard of test.
Very good. Very good. And we'll just close out this section of our meeting today just by saying thank you. Y'all are very busy. Thank you for driving to Frankfort to visit with us and help us understand this issue more thoroughly. We look forward to progress on these test and stay treatments and the monoclonal antibody treatments, and wish you well. So thank you so much. The next item on our agenda is our discussion of the impact of COVID-19 on our local utilities. And we have three gentlemen that are going to be here to testify. If you want to move forward to the table and have your seat. Mr. Larimore is here. Thank you so much for your patience. And we have maybe about 20, 25 minutes for you guys to give us some information. We may have a few questions to follow. So welcome and introduce yourself, please.
I'm Gary Larimore. I'm the Executive Director of Kentucky Rural Water Association.
Jeff Hurd. Bush. Jeff Hurd with President of Kentucky Municipal Utilities Association and also General Manager of Hopkinsville Electric System and EnergyNet.
Chase Azevedo, General Manager, Georgetown Municipal Water and Sewer Service.
Proceed.
Thank you, Mr. Chairman and committee members, for allowing me to be here to talk about the effects of COVID on water and wastewater utilities. I am the Executive Director of Kentucky Rural Water Association. Quickly, Kentucky Rural Water Association is a statewide association, trade association of public water and wastewater utilities. Currently, we have 360 utility members, which basically comprise 94% of all of the community water supplies in the state. First, I'd like to start off by saying thank you for your work in the 2021 session of the General Assembly. There's a couple items in particular I want to thank you about. Thank you. And the $250 million that was appropriated and authorized, basically the Clean Water program. There's $250 million went for the Drinking Water and Wastewater Grant Program. Thank you for that. We've been working with the area development districts and others trying to get that money together, and Kentucky Infrastructure, and we are proceeding nicely. There's a couple of awards that have been given out at this point, so thank you for that. The other issue I want to thank you with is the passage of House Bill 272, which was sponsored by Representative Bray. So Representative Bray, thank you for sponsoring that bill that allowed water and wastewater utilities to retain the ability to assess late payment penalties. And that's an important management tool that we had, and quite frankly, since the passage of that bill, it's kind of stopped the bleeding, so to speak. It has really ensured our cash flow. Also, it ensured utility employees remain classified as an essential critical infrastructure workers with that. So now I'm going to try to go into the financial impact quickly. I wish I had more comprehensive statewide numbers. Those are just hard to get together. We have two gentlemen here that I know will speak about their utilities, and so I'm going to talk about. I was able to get I guess a general manager's report from a manager who managed 3 utilities. The bottom line is not all utilities been affected the same. You know, they have different characteristics, whether they're urban or rural, or whether they're heavy in commercial, industrial, or residential. So I chose Warren, Butler, and Simpson County Water District, and it's one of those districts that is managed by one utility to manage as 3 districts, and they have a lot of different characteristics. So basically in that, just looking at those 3 utilities and I think this goes across the board, and I believe you'll find that here in just a second, but net income decreased with 35%, and we're talking about for the calendar year of 2020. The cost of COVID-19 operations for those 3 utilities was $288,000. Now what that includes is additional personal protection equipment, paid time required for the CARES Act, paid time during COVID protocol schedule, and other modifications like that as well. Let you know a little bit about the characteristics of Warren County. We're talking about one of the fastest growing areas in the state. They have about 31,000 customers. Butler County, right at 5,000 customers. Simpson County Water District, 3,500 customers. Warren County is heavy, and I'll say heavy. They depend a lot on commercial and industrial and uses, and what they found is that their actually cost of revenue, or actually their loss of revenue, is right at $403,000 due to late fees, due to loss of revenue from late fees, collection fees, reduction in customer usage, loss of interest income, etc. Now, when you're just talking about the cost of COVID operations for those 3 utilities, Warren County was $167,369. Butler was $32,000. Simpson County was $46,000. That equates in Warren County about $5.04 per customer, and that's just on the cost for the COVID cost operations. Butler County, $6.56 customer, and then we go to Simpson County, with more rural farms, etc. That's about $13.28 a customer. So basically, it was a negative impact on the utilities, and they continue to struggle. I would note that since about 2000, we've been following residential sales. Residential sales actually are going down; they're declining. So that impacts the financial stability of utilities as well. And I think you're going to see that trend continue, and it's basically talking about residential areas. Health departments mentioned a little bit about some of the counties were losing population. You know, that's going to add an additional impact on those utilities, particularly in Central Wheeler in your area and Eastern Kentucky. Because a lot of their debt, quite frankly, is based upon 10 or 20 year population projections and stuff. So now they have those fixed costs, and that COVID just impacted those in addition. Talking about late payment fees, estimated revenue loss for there again, just late payment fees for Warren County was $231,000, right at $232,000. The sewer division was right at $59,000. Simpson County Water District, $33,000. Butler County, which is a rural county, $37,000. This is an additional what we had mentioned earlier. And I went up to Oldham County, and theirs is roughly, it's a little over $27,000. And that's just on late payment fees and service fees that we were not able to collect during the session. For brevity, I'm going to go into basically a couple of our issues. And first, I'd like to just stop and say, you know, I'm proud of our industry and what we've done during this session. Heard the health departments talk about that they never stop. They work 24/7. Our industry is the same. You know, they're my heroes, quite frankly, because they're always out there. Workforce issues is one of those issues that COVID has really shined the light on us. We were short-staffed anyway. We worked on a small margin. With COVID, it just compounded all those issues. So we continue to struggle to find people, and I know you hear that on a lot of other industries as well. Very few people in school. think about what I want to do for a career, say I want to be a wastewater guy or I want to be a water person. I was one of those that actually my dad was the manager of a water utility, and I quickly says I do not want to get in the water business because it's hard work and they don't pay much, but here I am anyway. So on the workforce issue, obviously employee absence due to COVID, exposure, child care related issues, that still compounds. I talked to one utility yesterday, and they talked about in the last 2 months, over a third of their employees have been impacted by COVID, whether they tested positive or someone in their family or their child was exposed in school or daycare. So what do we do with, how do we fill those gaps? Well, the people that we currently have just fill in the gaps. They work more overtime, which is more cost to our utilities. Early in the pandemic, we were able to get a list of operators, certified operators that were willing to go to other utilities and help out in these situations. Fortunately, we hadn't had to use that list much, mainly because the neighboring systems have come together and it worked 12-hour shifts and then go to their other utility and work again. So, so I applaud their efforts. Supply chain issues, that is an extremely huge issue for our utilities now, and I've watched a couple of other committee meetings with other manufacturers and stuff. That is not new to you guys. You've heard that. It is impacting our industry. You were talking about delivery of parts, supplies, chemicals, pipes, fittings, meters, vehicle purchases, equipment. We can't get backhoes. We've had them ordered and still can't get them in. I had one utility tell me yesterday he was out of inventory. It's one of the fastest growing municipals in the state. He can't even do new meter settings. We've got a lot of houses being built, construction going up, and he's having to borrow meters and settings and stuff from other places. 120 days backlog, and they told them maybe another 60 days before they get anything. So we're just talking about everything is just bogged down and slowed down as well. We talk about the infrastructure bills that are coming in, and thank you for the money that's coming in from the federal government and state government. Unfortunately, a lot of these issues just talked about will impact the cost of that. Construction bids, awarding contracts, cost overruns, all of that is going to play into what used to be a $1 million project is now going to be a $2 million project. And just getting supplies, you can't get anybody to give you a price, guarantee a price. Basically, the price is what once those pipes is delivered that day, whatever the price is that day is what you're going to have to pay. And unfortunately, I think you see that across most industries. Obviously, this is all going to impact rates. So water has long been I think the value of water has not been, anyway, water rates are going to go up. It's inevitable. For the first time, one good thing about the pandemic, for the first time, there's been funds created to assist customers to pay water and sewer bills. For years we've had those just a lie heap and basically electric, but never had the water and sewer. Couple of programs that are out there, CDBG, coronavirus response, going through the Department for Local Government and through the ad districts, is getting some money out there to utilities as well. Healthy at Home Eviction Relief Fund, that's the other one that we look forward to, and utilities are starting now to get some money. It's taken a while. Any new programs that start, it takes a while to get that process moving. I think there was a press release just on an update, about $51.1 million from March to date has been expended from that program. 6.4 million of that for utility payments. I have seen a list from the water and the wastewater utilities and also electric utilities, and they are getting the money out. We're hoping that to be able to work something out that might streamline the process a little bit better, bulk applications from utilities. We can sit down, we've got a list of our delinquent customers, and right now we don't have the capabilities to just providing all that list on a regular basis to to the housing authority so they can process those applications quicker. We are working on that, and hopefully in the next couple of weeks we'll be able to get to that point. Lastly, Chairman asked me if we had anything that we wanted to talk about in the 2022 legislative session. We are discussing a number of issues among our industry, but I wanted to highlight one in particular, plant a seed, so to speak. Kentucky Rural Water Association started an apprenticeship program back in April 2019. It was registered. We had our first apprentice enrolled in September of 2019. We had our first apprentice graduate in August of 2021, so we're excited about that. We've got a full-time workforce development coordinator that's focusing on water and wastewater utilities. We do have workforce issues, and we need more qualified people. Currently, we have 68 applicants, apprentice applicants. We have 20 registered apprentices that are in the program, 15 registered employers. What that tells you, we've got more applicants than we have employers. So what I wanted to plant the seed about is that Kentucky employer incentives for registered apprenticeships. And currently there's 28 states that offer direct support to expand apprenticeship through financial incentive to employers. Kentucky is not one of those. However, Kentucky does offer some options for employers. The Work Ready Scholarship, but it's mainly for 5 high-demand sectors. Your public utilities, water and wastewater is not one of those high-demand sectors as the law states. So that's what we would like to plant that seed, to talk to you guys about it a little bit, and see if we can't get water and wastewater, our industry, included in that. That will only provide incentives to our local governments so they can start in the apprenticeship program, get some people right out of school, high school, or whether it's veterans or whomever, but get them into our industry, which we feel like is, obviously I've been doing this 43 years, so I think it's a wonderful industry to be in. So with that, Mr. Chairman, I'll turn it over.
Thank you, sir. And gentlemen, just continue. You can continue on, and we'll save our questions here till the end. So take it away.
Thank you, Chairman Mills and Chairman Meredith and the whole Joint Committee. Really appreciate the opportunity to be here today. And also I'll reiterate what Mr. Larimore said with House Bill 272. Really appreciate giving us local control. That's very important with the public power model, and especially all your work in the special session. So I'd like to appreciate that. KUMA represents 44 city utilities, and we provide essential services including electricity, water, wastewater, natural gas, and telecommunications. So I'll be brief. I wanted to kind of focus on HES's plight, what we've been through from a personal standpoint, even though what we're going through, I'm sure it mirrors what the other 22 electric utilities in the Commonwealth are facing as well. So just a little background on Hopkinsville Electric System. Of course, we're in the southwest part of the state, have roughly about 13,000 electric customers and about 4,500 internet customers. So we are also focusing on high-speed internet. So, of course, that was mentioned earlier by one of the other presenters. But back at the governor's executive order back in May of 2020 that issued a moratorium on cutoffs and late fees for non-payment of utility bills had a really significant impact on all of the city-owned electric systems, but especially HES. HES honored the governor's 6-month suspension of payments, but that left us with over $660,000 worth of delinquent electric and internet bills. And I guess at beginning in November, when it was lifted in November of 2020, we set up all of our delinquent residential and commercial accounts on a 6-month payment plan to cushion the blow and allow them time to pay off their account balances. What that meant for Hopkinsville Electric System was a total of about 84% of our customers completed those payment plans, while the remaining 16% had a total amount written off of a little over $105,000. In addition, HES will never recoup the late penalty fees, which conservatively we estimate a little over $55,000. I would also like to note that a portion of our customers would not apply for the Stay Healthy at Home or the LIHEAP or Community Action financial assistance until there was actually a threat of disconnection of electric and internet services. HES's objective is always to use every option to keep our customers' accounts current and active and to avoid disconnecting service, because that's not a benefit to the customers or our utility. We do continue to see customers struggle with their bills and are very grateful recent litigation to prevent restrictions on city utilities from disconnecting and charging late fees when necessary. So it's basically just giving us a tool to be able to work with our customers, because we know many of our customers are financially challenged, and when they get several $100s behind on their bills, that is a significant challenge for them. So we want to find every way we can, and we've implemented several programs and a prepay called Pay As You Go that allows them to kind of pay on a daily basis and gives them more control of their account. So that's one of the many tools that we're trying to utilize. Also, due to the surge in the Delta variant, HES and many other city utilities have closed their lobbies to in-person customer visits. So that's affected us on several fronts. We have seen our customers pay their utility bills at the drive-up window and by mail, or even through the internet IVR systems that we have in place now. So, and we continue to have all of our employees wear masks, temperature checks, and also staggering our work shifts to make sure that we eliminate opportunities to infect our whole departments. Based on our membership, we've looked in, there's kind of three reoccurring themes on the electric systems. The first one is a significant slowdown Mr. Larimore mentioned on supply chain. It's across the board. It's affecting electric utilities as well. High voltage equipment, especially pad mount transformers. So of course transformers kind of the key component in providing electric service. So it used to be weeks or a short time frame is now sometimes up to 6 to 9 months in some cases to get that piece of equipment. So that really hinders us to be able to meet the needs of new and existing customers. We also seeing supply chain issues with lengthening lead times for vehicles, conduit, other specialty electric equipment, specialized parts. So we actually had a substation upgrade that was projected to be about a year project, and it was 18 to 24 months before we could get that finished. So it really put a hardship on, really hurt us from a reliability standpoint when we don't have all of our options on the table to be able to feed our customers. And we're also seeing some vendors refuse to hold pricing for more than just a few days on several of these items. Secondly, our employees are having to use a large portion of their sick and vacation leave for children and other family members that are affected by COVID as well as themselves. So any assistance for employees would be much appreciated. And the last point is hiring, as Mr. Larimore mentioned, it's affecting on the electric side as well. Much more difficult not only for our utility system but our suppliers as well. We see that it's affecting several of the vendors being not only being able, the pricing on the items, but having employees for the transportation side of it. So we hope that will change with the discontinuation of the federal unemployment benefit. So just want to touch on those, and with that I'll hand it over to Mr. Azevedo.
Thanks, Jeff. It's appropriate that the Kentucky Health Department Association let us off today 18 months ago. Our local director of our health department in Georgetown, Wedco District Health, she asked me at that time, what do you need? We know this is coming, and I had no idea at the time, but I did tell her that any kind of crisis, if you want to make it worse, exponentially worse, have somebody turn on their light switch and the light not go on, or turn on their faucet and water not come out. It's something that we take for granted because it always comes out, the light always turns on, but I will say the last 18 months maintaining that level of service has been as difficult, has been as big of a challenge as I think we've faced in the utility industry. So that being said, I'd like to thank the chairs and the committee today for taking this opportunity to talk to us about these challenges, to hear what we've been facing the last 18 months. And I'm speaking collectively on behalf of all the city-owned water and wastewater utilities that are part of KMUA. And on behalf of those members and our customers, I'd like to echo what my colleague said in thanking you for your work on the relief on disconnects. It made a huge difference with House Bill 272 and further your work in the recent special session. So your effort is important as many city-owned utilities, water and wastewater, and our sewer districts, water districts have been very adversely affected by the health pandemic. We've had no choice but to manage these impacts of the pandemic, and navigating these unprecedented circumstances, it continues to be a challenge and will be for the foreseeable future. So just drilling down to some of the issues that you've already heard about. Pre-pandemic, Georgetown Municipal, for specific utility numbers, we had less than 2% of our customer base that had a past due bill, a past due account. Now, currently over these last 18 months, we're up to 15% of our customer base have past due accounts. And what's frustrating is we have that money through Healthy at Home available. The city and the utility have worked hard to make those funds, those relief funds available, and we can't get any applicants for those programs. We're kind of baffled by that. As you've heard in two previous testimonies, supply chain issues is the number one challenge. We are in the pipe business, and we cannot source PVC and ductile iron pipe. We cannot source the fittings for those pipes. Further, we can't source chemicals that we need for water and wastewater treatment. We can't source basic building materials, and we can't source, as we've all heard about, the computer chips that make our fleet vehicles run. We can't renew our fleet right now and get new vehicles. That will cause a problem. And when those products are available, we're paying a historically inflated price that is very difficult to budget for. So our factories, our vendors, our manufacturers that utilities rely on day to day, they're still not back up to full capacity, whether that's staffing, whether that's materials, transportation. It's just not there. So we don't know how long it's going to take to restore the supply chain, and we're unclear if new legislation can help that at a local, regional, or national level. Again, as you've already heard, not only do we have a material issue, we have a workforce availability issue. I don't understand it. There's help wanted signs everywhere, but we can't get people to apply for jobs. Again, talking about Georgetown Municipal specifically, this predates the pandemic, but the pandemic has exacerbated this issue. 5 years ago, for an open position, minimum of 20 applications. People wanted to come work for the water company. Today, we're lucky if we have 5 applications for an open position, and that's applications. That's not people that we necessarily want to hire. That's just applications. So when you factor in that we can't get materials, that it's not just the utilities that are facing staff shortages, it's also our vendors, our contractors, our suppliers. You take that and combine it with the fact that you might have to have one staffer or an entire department have to be out of work due to quarantine or a positive test. Maintaining that service to our customers gets very difficult. And again, to reiterate, our ability to have the materials to complete capital projects, operate and maintain our systems, maintain financial solvency, it directly impacts our customers, and also, just important, it directly impacts us being able to achieve regulatory compliance, which is becoming more difficult by the day. So we're here today. Jeff already mentioned 3 items, and I want to reiterate, we're requesting help. We need guidance from you all as best you can offer. We need help addressing the supply chain issue. I don't know what the answer there is, but this could take years to come back to normal, and it's significantly impacting our projects and our service. Any assistance, second, that can be provided in helping with sick pay when our employees have to be out, be greatly appreciated. And as I said, you've made relief funds available. You've done the heavy lifting. We got to get the message out, and we need help with that. We've talked about that PR effort, letting people know that there's programs available to help them. It's paramount. So while some of these requests might not be reasonably addressed in the upcoming legislative session, we do want you all to be aware of the issues we're facing, and we're happy that you've taken this time today to speak with us. So on behalf of KMUA, our president, Jeff, and our executive director, I'd like to say thank you, and that we're happy to answer any questions that you have.
Thank you so much. We have a couple of questions in the queue. Senator Wheeler has a question. And if Mr. Larimore, yeah, there you go. Come on up.
Thank you, Mr. Chairman, and Gary, it's good to see you here today, and I enjoyed working with you on the wastewater task force. It's really kind of more of a comment and a question. I know that we've discussed this on many occasions, the difficulties in providing services to rural areas. You have the greater distances, which requires more materials, and as well as fewer paying customers because of the lower population densities. I guess long term, what are you seeing that we as a legislature, what kind of policy positions or creations could we put together that might alleviate that problem? And then, Mr. Chairman, I guess after he answers that question, I'd just like a privilege to make a very short comment.
Sure.
Well, this is my personal opinion, and
microphone, please. Your mic.
Oh, I'm sorry. That was probably the best answer I get without the mic. So, well, it's an interesting question. Kentucky's done a wonderful job of getting water out into the rural areas, back starting in 2020 plan. Now we've got a little over 96% of population served by public drinking water supply. That certainly doesn't come without its issues as well. We still have a few areas that hadn't been served, and usually the easier areas have already been served. So in the future, what the General Assembly can do is unfortunately what we have to do is go back to where we began. A lot of our utilities, even our youngest utilities, were built I'm talking about water districts, 1960s, late 60s, early 70s. So as you can see, they're already aging. So the additional money that's coming in for infrastructure, a lot of that may not necessarily be to go out into the areas and serve more population, but to come back and look at new water treatment plants, upgrading those. We might even have to build new treatment plants as well as upgrading the existing pipe. The pipe material, and a lot of that is no longer like AC pipe, asbestos cement pipe. You really don't get that anymore. We need to replace a lot of that for various reasons. Lead and copper rule that's coming down, and lead goosenecks and stuff, and for the lack of that will have to be replaced. So I think you're going to see a lot of that funding that comes in is going to have to be going back towards the older parts of the system to get them up viable, so we can continue to provide that pressure and service out to the rural areas. So, in short.
Yeah, some of the comments about the supply chains, have been very concerning here today. And I think this is something that's been building up for a while. And, I think there's enough guilt to go around here with the outsourcing that has taken place over the last 25 or 30 years with some of these disastrous trade agreements that have hollowed out American industry, outsourced things to communist China, which is definitely no friend of ours. At least I think in the last presidential administration, there was some emphasis on reshoring that I think was actually starting to happen a little bit, and then COVID hit and really turned that awry. And it seems to me that with the current administration, we're seeing a bit more of what we saw with when Main Street was sold out to Wall Street through NAFTA and a lot of these other deals. I think I just saw that maybe I think it was Rawlings Company or one of the other sports manufacturers was outsourcing baseball bats to China. So I guess, It seems like American industry, or at least Wall Street, doesn't seem to have really learned a lot of the lessons that I think they should have learned about this pandemic and what that government did to us, and it has led to the death of nearly 800,000 American citizens by their malfeasance in managing the COVID-19 pandemic when it first hit. So, and I guess it's even trickling down now here to providing basic services to the citizens of the United States. So I do hope our federal leaders are listening. I do hope that they are concerned about the people that live in this country, that they get the services that they need provided to them, and that we quit being dependent upon foreign adversaries that really have no concern for the United States of America and are ideally opposed to us and the democratic principles that we stand for. So I really appreciate you guys coming down here today.
Thank you.
Representative Thomas has a question.
Oh, well, it's more so a comment, Mr. Chairman. I want to thank y'all for being up here. And Senator Thayer, you constantly have constituents that pop in front of our committees because of your proximity here. But my constituent drove about 3 to 3.5 hours to come up and visit. So this morning I was joking with him. I said, I can't believe you drove this far just to come see me and our committee and everything. And he said he had alternative motives, that he actually want to congratulate him on his first grandson, about 10 days old, that lives over in Lexington. So I thought it was us, but it really was a grandson. So thank you for being here.
Representative Donahue has a question.
Thank you, Mr. Chairman. My question's for Jeff. You set up 16% non-payment. Was that one specific area or overall?
That's overall. I guess the vast majority, I guess it was more focused on the residential side, but it's kind of across the board. And as I mentioned, it is interesting to note that once just had they had the sense of urgency to make those payments. I guess worst case scenario, we had one customer between $600 and $800 in delinquent accounts, and we'd mentioned to them there is financial assistance available, and they mentioned, well, until I'm forced to pay it, I'm not going to. But we did follow through with that person, and they were able to, about 75% of that was they were able to get financial assistance, but it was after the point they needed a little bit of urging. So, you know, that's the quandary that we're in. But so the monies were out there. We look at the disconnect as just a tool. It's not like I said, it's not our purpose. Our objective of disconnecting is getting our customers current with their bills and providing them quality service.
Thank you, Mr. Chairman.
Very good. That is the end of our questions in the queue, and I want to once again thank you, gentlemen. You all, similar to the public health authorities here that were here, you're very busy at the tip of the spear on the pandemic, and I want to thank everybody for participating in all the good work that we're doing out in our communities. So before we leave, are there any participants on Zoom that wants to chime in and let their presence be known? Anybody miss the roll call? All right. If not, have a motion to adjourn. All in favor say aye. We are adjourned. Thank you.
Aye.